from 5 a week in August. An overall spike that the district is warning school leaders about. Left sent this letter to superintendents in the region.
Good evening, everybody. We're just going to wait a couple more minutes for people to join and we'll get started. Thank you for joining us. Good evening, everybody. I think we'll get started now. My name is Wynn Everts. I'm the Executive Director of the ARC Connecticut. Thank you very much for joining us tonight. Before I introduce our wonderful speaker tonight, I just want to go over some logistics for the evening. All of you will be muted throughout the presentation. You will have the ability to ask questions. If you'd like to ask a question, please open up the chat feature, and you can do that by hovering your mouse or trackpad, whatever, down at the lower part of the screen, and you'll see something that says chat. You can click on that and it'll open up a screen to the right where you can ask your question. And please type it there. This is a really important and also a really personal subject we're going to be talking about tonight. And because we have a limited amount of time, we're going to try and prioritize those questions that address a lot of people rather than, say, a question that's about one individual person. I think that our presenter is very willing to talk about individual cases and things like that privately for a number of reasons on a presentation like this. So without further ado, let me introduce our presenter. Our presenter is Dr. Lisa Weisinger. She's the mother of a 25-year-old son with Down syndrome and an internist in Hartford with a special interest in the healthcare needs of adults with disabilities. After experiencing her own challenges in obtaining healthcare for her son, she founded the Connecticut Healthcare Advocacy for Adults with Disabilities, or CHAD, an organization that's committed to addressing healthcare inequity for adults with disabilities. As part of this mission, Dr. Weisinger has dedicated herself to educating healthcare professionals and families on how to identify and collaborate in meeting the healthcare needs of people with IDD. And so I'd like to welcome Dr. Lisa Weisinger. The floor is yours. And you need to unmute yourself.
All right, I'm unmuted now. Perfect, okay. So thank you very much to the ARC of Connecticut for inviting me to speak to you, and thank you to all your family members who are on board this evening to listen. I do have one disclaimer, and that is I am not an expert in medical issues associated with adults with intellectual and developmental disabilities. I am an expert on Jamie Rowland and his medical issues, which made me have a little bit more experience in that realm. And I'll tell you a little bit about our journey from the pediatric population to the adult care population, which was bumpy at best. So my son is 25. My son has Down syndrome. He has allowed me to speak about our journey. I did have to ask him permission. And our journey started when he was about 18. And we decided, my husband and I are both physicians, we decided that we were going to move him from the pediatric population to the adult care population. So we were moving from the pediatrician to the internist. I'm an internist by trade, but I actually took 20 years off to help Jamie. And I just went back to work about a year ago. I teach medical residents and medical students in one of the local hospitals. So this is a new endeavor for me in terms of going back into practice. And one of my main issues is the fact that we really had a difficult time transitioning into the adult care population. So that being said, just a little bit of background is ID affects about 1% of the population globally. So we're talking about a huge number of people. And traditionally in medical schools and nursing schools, they don't have a lot of training, or we didn't get a lot of training about our population. So one of the goals of the CHAD organization is to educate healthcare professionals. Again, not just physicians, nurses, physical therapists, occupational therapists, anyone who sort of touches the lives of our family members or people that we want to reach out to and train them about our population. So one of the things I want to sort of get everyone to understand is that preventive healthcare is where we really need to be with our adults. So we need to make sure that they have the appropriate preventive healthcare to live a long and healthy life. Our family members are living longer, thankfully, with a little bit of help from us that they can stay healthy, stay out of the emergency rooms, which helps us financially. It helps the healthcare industry financially. So they're not there, and our family members deserve the best that we can offer them. So some of the things I talk about with the healthcare providers is that really preventive healthcare is very similar to preventive healthcare for any individual above the age of 18. Vaccinations need to be reviewed and updated. Right now, make sure all of your loved ones get the flu vaccine. I usually like to start in early to mid-October, giving the flu vaccine. Medication review should be done, I like to say at least once a year, if not done every visit. A lot of our kids, we'll talk about the idea of polypharmacy, which is a huge issue with a lot of our kids, meaning they have a lot of medications that may interact with other medications, and they may be over-medicated. So that's important for everyone to either bring a list of their loved one's medication with them when they go to the physician, or bring the medication bottles with you. So that being said, we're going to start off with just what we need to look for as individuals, what I am teaching the healthcare professionals about our individuals, and basically what I've chosen is the top 4 or 5 medical conditions associated with the IDD community here in the state of Connecticut. We'll talk a very little bit about health disparities, which is a very vogue thing right now. Grand rounds at my local hospital is having a big grand rounds on this in 2 weeks about the marginalized population. Rarely do they ever mention our population when they talk about healthcare disparities, but we have a huge problem because the medical community isn't aware of our needs. So we're hoping to change that little by little. This is the slide that I usually show medical professionals that in terms of having new patients with an intellectual or developmental disability, they need to have more time. And you need to be upfront when you schedule an appointment to let the physician's office know or therapist's office know that you have an individual who has some special needs and may take a little bit longer. So these are the things that you need to talk about upfront. Who is going to speak for the patient, who is going to speak to the patient, and who's going to be able to give consent. Is your child, your loved one, excuse me, my child, able to give consent by him or herself, or is there a guardian who has to be available to make those decisions and to give consent? I teach them about person-centered approach and using the right terminology. When they talk to someone, look someone in the eye. If someone is in a wheelchair, please get down to his or her level, sit down in a chair. And even if they are nonverbal, speak to the patient. Don't speak to the individual with the patient. And it'll take a while. Sometimes the staff is a little bit reticent, but with the proper coaxing and with a little bit of enthusiasm, I think that they can do a really good job of incorporating our patient population into their own community there. So in order to ensure success in advance, who's going to advocate and who's going to accompany the patient, make sure whoever is with the patient is able to give consent, because there may be some procedures that need to be taken care of or scheduled. Bring a list of medications, medical issues, especially for that first time, and also bring a list of questions. A lot of times I ask people to bring in a notebook. If they have questions, write them down in advance, and then write down the answers when you're there. We do a wrap up where I work. So basically what I tell people is, I'm going to tell you what to do. You can write it down. I will put this all in a wrap up so it's in physical form so you can actually take a look at it. And we're trying to be more accommodating with our patient population. We're moving from a paternalistic system to a more accommodating patient-centered system. Sometimes we have a little bit of issue with that, but I think overall we're doing a really, really good job. So in between all of this, I'm going to try and give you some clinical vignettes to let you know that sometimes I win the Mother of the Year award, sometimes I don't. But Jamie has been, sometimes can be troubling, can have some very difficult issues. So one of the things that he had a behavioral change many, I don't know, 5 years ago maybe. We didn't really have a good psychiatrist here, so I asked a friend of mine who's in it to send us to a psychiatrist who has experience, I didn't even want to say expertise, working with our patient population. So we went in to see him, and he actually had quite a number of people with IDD in the waiting room. So I felt kind of comfortable, thought, okay, well, he's got to know what's happening. And Jamie's behavior had gotten a little bit out of control, so we went and talked to him. So it was me and Jamie and this gentleman in the room. And he asked every single question to me. And Jamie was sitting right there. He said, how old is he? And I would look over at Jamie and I'd say, Jamie, how old are you? And then Jamie would answer, he's 25, whatever it is. And he would say, well, what kind of behaviors are you having? What kind of issues are you having? And I would say, Jamie, what kind of behaviors are you having? But this is a gentleman who was supposed to be an expert in the area, who was looking at me, talking to me, and totally disregarded my son. So basically all he did was say, okay, well, I think we're going to increase this medication, which was it wasn't a psychotropic, it was an antidepressant. I purposely don't tell people that I'm a physician because I want to make sure that they're doing what they're supposed to do and not treating me as the physician. So the gentleman didn't ask any problems. It didn't ask about Jamie's medical issues. He had no way of knowing what his medical issues were. Didn't know anything about whether he had labs recently or not. So he just assumed his behavior was secondary to a psych issue, as opposed to, well, maybe his behavior is secondary to a somatic issue or a medical issue. So one of the things I tell you is don't always assume that behavioral changes are because of a psych issue. I think we all need to be a little bit more aware of what potential medical issues can be masked as a behavioral change. So that's why I want to talk to you about what some specific changes that our adults go through that may change their behaviors. And they may not have the language to be able to tell us something's wrong. My tooth hurts, my foot hurts, my stomach hurts. And the behaviors can be manifested in a multitude of different ways. So don't assume it's a behavioral problem. And we'll start off with some of the medical issues associated with autism. Two of the major issues that we need to worry about as our adults with autism age are seizures, which can be almost a third of the population. They can present as, at any age, first of all, they can present as sleep disorders, behavioral changes, or any kind of regression and development. So just be aware of that. A lot of the neurologists are aware of that in our patient population, especially as the population of people on the spectrum sort of explode. So they are getting a little bit more interested in the behavioral changes associated with seizure disorders that may not manifest as true grand mal seizures. And one of the things we'll talk about, you'll hear sort of consistently about a lot of the medical issues associated with our aging population is mental health issues. And that can be up to a third of the entire adult population in a multitude of different IDD conditions that have mental health issues. I've had a little bit of a difficult time trying to find good mental health providers in the state of Connecticut. I'm not saying there aren't, because I'm sure there are great mental health providers. I haven't found one that fits my needs, actually my son's needs. So we actually end up going to Boston to get to find someone who had experience and expertise in the area of mental health conditions associated with adults with Down syndrome. And the mental health conditions associated with our population run the gamut of somewhat like anxiety, OCD, depression, ADHD. They run the gamut. A lot of times you'll find people who have behavioral issues who are on the spectrum are given antipsychotics to help modulate their behavior. Some of it is for good reasons. Some of it may not be the best drug choice. So always be aware of what our loved ones are taking, why they're taking it, and when they use it, we call it off-label. So things that are antipsychotics, we may not use as an antipsychotic. We may use for behavioral change, behavioral modifications. So not all the time are we supposed to say no to antipsychotics. It may very well help in the short run and sometimes in the long run, but just be aware that and talk about it. Why are you putting my son or daughter on this medication? Please explain to me, are there any other choices for that? Some of the other issues associated with autism or sleep disturbances, I'm sure many of you who have young adults or adults can attest to this. The sexual aggression, as you know, comes out around puberty, can be very devastating. Kids can get in really big trouble at school because of the sexual aggression. So we have to be super careful about what happens, why it happens, and how to help them around this issue. Oral health is a big deal. You'll see it again in a lot of the different conditions that we talk about. Oral health, dental cavities, caries, people with gingivitis, etc. So we have to be super careful about making sure our kids brush their teeth at least twice a day and do it again for a minute. I tell my son, sing happy birthday. Sometimes he speeds through happy birthday and I'll hear him, sometimes he doesn't even put toothpaste on the toothbrush. So we sort of have to be vigilant about making sure our oral health is in good repute with all of our kids. GM and metabolism, again, is going to be a bigger issue with all of our adults. Constipation, diarrhea, irritable bowel, and gastroesophageal reflux. Sorry, I should have put that out. But reflux, meaning someone has acid that's bubbling up from their stomach into their esophagus, can cause a lot of GI distress. They can feel like they've got heartburn, they can feel gassy, they can burping, etc. And just to let you know, again, I could be like mom of the year. My son was complaining a year ago, March, that he would get up 2 o'clock in the morning and throw up. And he stopped eating, lost 10% of his body weight. We couldn't figure out what was going on. We actually never saw him throwing up, so we're assuming he didn't feel well. Didn't really complain of any abdominal pain, but kept saying, you know, I'm throwing up, I'm throwing up. It took us a while to understand the fact that he had significant stomach ulcers. And it took a very, very smart internist to say, hey, you know what? We need to test him for Helicobacter pylori or H. pylori, which is a bacteria that can cause ulcers in the stomach. So it's been a year and a half. Jamie's still sort of suffering through all that. He goes up and down on his medication. He's had 2 endoscopies. So we're really careful about his diet, as well as he has a penchant like his mother for Diet Pepsi, which is not allowed to have, but he's manipulative and he sneaks them. He can't wait for us to leave the house so he can go and get a Diet Pepsi in the basement. I try to hide it, but he seems to find it. Another medical issue, autism, is pica, eating inedible objects, dirt, usually wood, rocks, whatever it is. So we need to be vigilant about what they put in their mouths. Medical issues associated with adults with cerebral palsy, a lot of them center around joints, bones, muscles, difficulty walking. 25% of the people who are walking as children may not be able to walk as they get older. We just need to make sure that they don't have any nerve entrapment. They also have problems with osteoporosis. They have sort of bone demineralization, so we need to make sure that they get something called a DEXA scan. It's DEXA. Sooner, usually we check those for women who are postmenopausal. We'll have that just as looking for a preventive healthcare in terms of osteoporosis. So they have a lot of GI complaints also, gastroesophageal reflux, they have constipation. And dental health problems. So again, you'll hear a lot of the same conditions or issues in a lot of our populations here. So just keep aware of some of the things that you have to be aware of for making sure that our kids get the right preventive health care, and that we're watching and educating our healthcare providers, because truth be told, we don't do a really good job of training our medical professionals about our population. Again, post-impairment syndrome with CP, they use more energy than we normally do to move around, which shows up in weakness due to muscle abnormalities. So there's a lot that goes on in joints and muscles that we need to be aware of as they age, and just generalized fatigue. Again, they can suffer from mental health disorders and seizures. So some of the things, again, prevailing around mental health disorders, seizures, GI issues. So here's where I shine. This is my area of expertise, because this is my kid. So one of the things that we worry about as family members of young adults with Down syndrome is dementia. It's an early onset, mainly in their 50s. We look at, excuse me, people who have behavioral changes. Again, Jamie had significant behavioral changes, I don't know, maybe 5 years ago. And I called up my friend who is a dementia specialist in adults with Down syndrome. And I said, oh my God, my son has dementia. And he's like, Lisa, your son is 20. He doesn't have dementia. But it's one of the things I constantly worry about is early onset of dementia. And it's real, it happens. Again, it's a maybe 30% risk as pardon my vernacular, as people hit 50, and it increases significantly every 10 years. So every decade they age, the risk of dementia, Alzheimer's, increases dramatically. Hypothyroidism is a problem from birth. You have to check it every year. So when we moved our son from the pediatric population to an internist, we actually used a friend of ours. And I went in the very first time and I introduced him to Jamie, and I said, one of the things that you need to know is that every year Jamie gets a TSH, so a thyroid stimulating hormone. Is looking for evidence of a thyroid that's not active, that's underproducing. And it has all sorts of problems with mental health and mental acuity, not being able to think right, your heart slowing down, all sorts of really, really horrible things. But if you catch it early and we treat it quickly, it's not a problem. So he refused to do a TSH on him, or a thyroid stimulating hormone on him. He said, we had one last year, we'll do it again next year. I'm like, no, we're gonna do this every year. And he fought me on it. And so I'm like, you know what, I'm pretty much done here. So that was the first internist that we went to, when we sort of said, okay, thank you, we have a disagreement and we're moving on. Jamie had sleep studies done for obstructive sleep apnea 3 times. And he refused to let me show you the pictures, but it's that horrible picture of all the kids have those things, on their head. They've got, it just looks awful. There's all sorts of electrodes attached to their head, attached to their heart, attached to their arms. And they say, okay, you've got 75 different tags on you. Now go to sleep. And you're in a hospital bed in a very weird environment. And Jamie stayed up all night, and that was twice. We had it done, and 5 o'clock in the morning, they just said, forget about it. So we finally did one, about 4 months ago here in the house. Thankfully to COVID, they come up with new and creative ways to do a sleep study in your house, which is fairly non-invasive. And the pulmonologist called me and said, Lisa, I've never seen someone with such bad sleep apnea in my life. How did you let this go for so long? So I'm not as objective as I'd like to be. So now we're wrestling with trying to get him a mask that he will wear on his face, because some of them can be very claustrophobic, and the air that they sort of blow into, it can be kind of harsh. So obstructive sleep apnea is really, really common in our adult population with Down syndrome for a variety of different reasons. But it's a really important monitor to check on, because if they do have obstructive sleep apnea, it could lead to significant lung and heart problems. So please, if you have a child or a young adult with Down syndrome, please get that checked out. Again, depression, anxiety is all part of it. It gets worse with age. As our kids get older, they leave the school system. So they now are socially isolated. Some of them can't talk on the phone, can't use text messaging. Especially with COVID now, they're completely isolated. As the days and months wear on, they become a lot more depressed than they used to be. So this is something to check on and make sure that our kids get what they need. Again, they have osteoporosis, so a DEXA scan, which we normally reserve for women who are menopausal, they get usually in around age 50, just to check for osteoporosis or thinning of the bones. Fungal nerve infection, obsessive compulsive disorder, all mental health issues. And again, gastroesophageal reflux. My son has that. He also has stomach ulcers, which are very painful, and didn't have the language to tell us, which was killing us. So just be aware, if someone's behavior changes, it can be a manifestation of a medical issue. And one of the biggest problems I see a lot with our population is something called polypharmacy, where our kids are given too many pills, multiple pills. Maybe they have maybe 3 or 4 different doctors who may not be communicating with each other. So they may be prescribing similar drugs, but may not have the exact same name. And so they are taking too much medication, or medications that may interact with each other through no fault of anybody's. But it's really important for all of us to bring the medication with us, or at least a list of the medications with us and how much they're taking. One of the things that we're working on with, there are PhD candidates in pharmacy in the hospital that I work in, and they're taking on this whole issue of polypharmacy. So I'm really excited to see what they come up with, and sort of stopgaps to make sure that we aren't giving our kids more medication than they actually need. So again, some more of some of the issues associated with Down syndrome. One of the controversial things that came out a couple of years ago is that should we vaccinate our young adults with Down syndrome for pneumonia, a pneumovax vaccine. And it was all the rage a couple of years ago. And I actually had Jamie vaccinated because Jamie when he was 13, was hospitalized for double pneumonia. Ended up 5 days in the hospital on oxygen. I actually told them I had young, Jamie's my oldest. I have 2 other children besides him, and I had to go home. My husband is a cancer surgeon, and I had to be home. I didn't have any help there, so he actually left the hospital on oxygen. And the pulmonologist was not happy, but I had to get home to take care of my other kids. Another thing is vision impairment, other causes of, so they need to have their eyes examined every single year. Cerumen impaction is just wax impaction. They tend to have a lot of wax buildup for whatever reason. They tend to have very, very tiny ear canals, so that could really impact on their hearing, especially when in the educational process. Conductive hearing impairment is just fluid or wax that gets in the way of hearing. Pseudo-dementia is something that we talk about with a lot of our patients in terms of they act like they have Alzheimer's or some kind of dementia, but actually they have some medical condition that has yet to be checked. So depression, any kind of mental health condition can cause pseudo-dementia. Transition difficulty, and I don't think anyone talks about this a lot, but transition can be anything. It could be something as minor as changing times for their job. But the biggest transition is the death of a loved one or a death of a friend, someone who they feel very close to. That can cause an immediate shutdown and have some significant mental health issues. So the more we learn about it, the more we realize that even minor transitions can cause significant issues in our population. So just be aware of it. We have friends who've gone through some significant trouble with the death of a grandmother, and their son, who was on the spectrum, actually had to be hospitalized emergently, and they were not expecting it. They didn't think it was going to be a big deal, but it really tore the family apart. So just be aware of that. Anything that can cause you to have a hearing or vision problem, make sure our kids get their eyes checked and their hearing checked at least once a year. Thyroid disease, more than hyperthyroidism can cause a dementia, slowing down of the mentation, slowing of the heart rate, etc., can really cause some significant issues with mentation. Sleep apnea, as I well mentioned with my son, I am still amazed that we didn't catch it earlier. Celiac disease, which is actually a higher preponderance of celiac disease in people with Down syndrome at any age, not just in the pediatric population. So they should be checked if they're having diarrhea, abdominal pain. Those are some of the things we need to look at and have it checked out. Again, not just in the pediatric population, it can occur at any age and can cause behavioral changes too. Arthritis, seizures, pain of any source can cause pseudo-dementia or behavioral changes. So just be aware of this, because some of the medical professionals may not be, and they may just assume that he or she has dementia. And it's a little bit more difficult to really elucidate dementia because it actually is a diagnosis of exclusion, at least at this point. There are some mental status exams that are geared toward our patient population of people with intellectual disabilities. But again, it's a diagnosis of exclusion. Our kids with Down syndrome also have a C1, C2, which is cervical spine instability. And if at some young age, they used to tell you that you had to have an x-ray of your spine before you can do any kind of sports. And I'm not sure if Special Olympics still requires it, but just be aware that if they're going to have general anesthesia where their neck, we call it hyperextended, a lot of times the anesthesiologist will require you to get an x-ray of their spine to make sure that there isn't going to be a problem as they intubate the individual for surgery. And just to let you know, there are individuals, my son is included, who have a decrease in cell-mediated immunity, which means that they are at higher risk for leukemias in the pediatric population, not so much in the adult population, thank goodness, but they are at an increased risk for infections, especially the pulmonary infections. So just be aware of that, and sinus infections. Just be aware of that. Cardiac issues, a lot of babies with Down syndrome, as you know, are born with significant cardiac issues and are usually taken care of very, very early in their, the first couple of months of age. And they just need to be followed up with a cardiac surgeon probably once a year or so. They are at a lower risk for hypertension or high blood pressure and coronary artery disease, which is nice. So I told you a little bit about Jamie and his thyroid check and my friend who refused to have his thyroid, so we left his practice. So I did tell you that Jamie did have double pneumonia, was put in the hospital when he was 13 for 5 days. The pulmonologist who was, first of all, he was hospitalized on a Saturday, and we now have hospitalists. So Jamie's pediatrician didn't go to the hospital. There was a hospitalist there, and we said we would like our son to have a pulmonary consult, a lung doctor consult, because we saw the x-rays. We were able to read the x-rays and notice that he had, we call it whiteout. So he basically had fluid in both of his lungs. And she said, well, it's not necessary right now. And we said, yeah, it's really necessary right now. She's like, no, he'll be fine, he'll be fine. And I looked at her and I said, would you allow your son or daughter to come into the hospital with double pneumonia and not be seen by a lung doctor? And she said, well, my son or daughter is not like your son. And I said, well, what do you mean? And she said, well, you know what I mean. And I said, no, I have no idea what you mean. So she was intimating that my son is less than, because he has an intellectual disability, and they were going to do less than for him because of that. So somebody in the community let our pediatrician know, and our pediatrician came around that night, and the pulmonologist came in about 5 minutes behind him. So we just have to be aware that people still have that bias, and it's not fair, and it's judgmental, but just be aware of that. And don't forget to fight. If your son or daughter needs, or your loved one needs something, you are probably not wrong. And just make sure that people know that it's their right to have it done. So the pulmonologist came in, and our pediatrician left, and the pulmonologist said, and Jamie, of course, was gasping for breath, and he was on oxygen, and they had this vest on him that vibrated to help get some of the secretions out of his lungs. And so he was sort of like a wet noodle. He wasn't answering questions very well. He was really trying to work to breathe. And so the pulmonologist didn't say anything, but he didn't do much. And I said, well, what kind of IV antibiotics are you going to put him on? And so he sort of hemmed and hawed a little bit. And I said, are you going to put him on triple antibiotics? And so we had a long conversation about what antibiotics we're going to put him on. So I wanted to make sure that he understood that I was not going to let him give less than, because my son has an intellectual disability. So that being said, we sort of got through it. And then when he was out of the hospital for 2 weeks, we went back to the doctor's office, and I reintroduced him to Jamie, and he's like, oh my God, I can't believe how smart he is. And I said, well, did that change your opinion of what you could or should have done with him had you known how smart he was and how capable he was beforehand? So it was just sort of a learning experience for me, a painful learning experience for me, but a learning experience nonetheless. So that being said, we're going to move on. So Fragile X, I think, is the last condition that I'm going to talk about. And again, we have the same thing. There's anxiety, mental health disorders associated with them, recurrent ear and sinus infections, which are also famous in the Down syndrome community, flat feet, high arch palate, which can cause some feeding difficulties, double jointed fingers, which can cause some issues with joint mobility as they get older, with a hyperflexible or hyperextendable joints. A lot of them are associated with autism. And the increased risk for aggression needs to be addressed also to make sure that we're not treating the aggression and making sure there isn't any underlying medical or somatic issue associated with their behavioral changes or aggression. And then finally, well, almost finally, I have to talk about a difficult topic, which physically makes me ill to talk about and think about with my son, but the assault statistics are there. 60% of our population has an increased risk for violence, physical, sexual, caregiver violence. We just need to be aware of it. And we have to make sure that our medical community is aware of it, because they don't do a good job, again, of teaching this in the healthcare community. And we need to be vigilant as a community to come together and present this as a possibility. The ARC of Connecticut is really avant-garde about this, and they're going to have a full presentation about some of the difficult subjects to talk about, as well as sexual health. So that's going to be an upcoming presentation, hopefully in the next couple of months. Some of the things that we sort of touched upon during the presentation, I feel like I've been talking for like an hour now, are the commonalities associated with all of our IDD community. And those are real. They are the mental health issues, the seizure issues, the polypharmacy issues, mental health, and then of course the GI issues that are associated with some of the IDD conditions in our patient population. So the main theme is that we need to be aware of these things because our physicians or healthcare providers may not be aware of them. I am happy to provide my slides to anyone who wants them. What I did with the second provider so Jamie's 25. We started him when he was 18 to transition him from the pediatric population to the internal medicine population. We've gone through 4 internists since he was 18. And I basically went into one of the offices and said, hey, look, you're a good person. I know you as an individual. Would you be interested in learning about Down syndrome? I can give you all the information you need to know about the medical issues associated with Down syndrome. And he said, absolutely. So I handed him my 2 or 3 slides of medical issues associated with Down syndrome. And he said, great, this is fantastic. I'll look it over and we'll start from there. So even if your healthcare provider doesn't know much about your loved one's issues, provide them with the opportunity to get to know them. And hopefully they'll say, I don't know much about cerebral palsy or much about autism, but I'm willing to learn. Can you give me some resources? And I'm happy to provide them with resources or get you to some other resources in the area that can be very helpful to healthcare providers to help our sons and daughters get what they need in terms of preventive healthcare to lead a long and a very healthy life. We touched upon something called CHAD, which is the Connecticut Healthcare Advocacy for Adults with Disabilities. We started that organization, I guess, about 4 years ago. We have volunteers statewide who are helping us to educate the Connecticut population about the medical issues associated with our population. So if anyone is interested in joining us, it's an all volunteer organization. We have physicians, nurses, parents, Autism Speaks, the ARC of Connecticut, Jewish Family Services, Fragile X Society. We fully have touched upon every major organization that provides information or education about some of the medical issues or medical conditions. So if you're interested in that, we meet virtually. Actually, we haven't met in quite a while, but we meet virtually and we give lectures to different healthcare organizations. So we did the Wheeler Clinic, physician's assistants out of St. Joe's. We talked to the Connecticut physician's assistants down in the Mystic area. We've given a lot of talks sort of around the Hartford area and greater Hartford area. And we're looking to increase our spread. Yale does a nice job of it. We worked with Quinnipiac and they got a new grant. The medical school got a grant to help educate medical students and some of the other healthcare providers there about our population, our aging population. So we're working hand in hand with them and they're doing a wonderful job providing the educational material needed. So with that, I think I'm going to end. I think I've talked way too long.
Okay, so Lisa, could
Yes.
you explain to one questioner what the acronym CHAD stands for?
Sure. So we started this, there's just a bunch of volunteers throughout Connecticut, and we needed to name ourselves. And basically what we're trying to do is educate the healthcare community about our population. So it stands for Connecticut Healthcare Advocacy for Adults with Disabilities. So we basically will go in and speak to any organization that wants us to come in, and we're totally free, about the healthcare needs of our population. So young adults, so anyone from 18 all the way to the end of life. And I basically give this presentation. We give another presentation to nurses. There's another presentation that we have for, who do we give it to? The PAs, the nurses, the medical staff. Oh, and also mental health providers. We have another one for mental health providers too. And this is the first time that we've actually done it. So I'm part of CHAD. I don't know if I want to call myself the president, founding member, whatever it is, to a group of parents. So I would love to get your feedback as far as what was good, what was bad, what could be reviewed or revised. And hopefully we'll get the word out to the healthcare providers who are taking care of your family members, especially those in the rural communities who don't have the opportunity to come into the larger areas. And so we're happy to provide them with whatever they need to educate themselves. Does that make sense?
Yes, it does.
Okay.
So if participants aren't looking at the chat, they should, because there's some people chiming in with some really great resources for people to use. So I'll just mention that Special Olympics has a Healthy Village that provides athletes with health screenings, and it's suggested that would be a great place to educate families about CHAD.
So Special Olympics is on our CHAD committee.
Fantastic.
I forgot to mention them. Yes.
The other thing is, do you have a list of recommended websites or other resources for families to get comfortable with in terms of navigating?
Navigating the medical community, navigating.
Yep. Yeah.
So do I have resources? No, but I can get them. I have resources for just people in the community who work with our population. But I can certainly do that, and I can certainly use. I can be the filter for whatever you need and provide that. But I will. I'll start pulling that together.
That would be fantastic. You've covered an awful lot of ground here.
I'm exhausted.
Okay. The question's being asked, do you think it would be better for our children to stay with pediatric care for as long as possible before transitioning to adult care if there are medical conditions that appear before age 18?
In retrospect, yes. And I'll tell you why. Because the pediatricians, at least in our experience, have always been wonderful with getting you in the day that you call. My son is sick, he has an earache, whatever. Usually they'll see you that day, if not within an hour or so of calling. Internists are a different breed. It's difficult to get an appointment with them in a reasonable period of time. And again, I consider myself one of those people. And a lot of times it's hard to get through to the doctor. So if you get to the receptionist says, I'm sorry, we don't have another appointment for 4 months. I'm not aware of that. I have no idea that my receptionist said, Wynn's son wanted to come in, but he was told he can't come in for 4 months. So I give my special patients, meaning all of them, my cell phone number and say, look, don't abuse this, use this. and if you have a problem, absolutely give me a call. But in retrospect, I would have stayed with our pediatrician for as long as he would have Jamie. and not kick them out. I just think that they do an excellent job. And as internists, we're still learning how to do that with our patient population. I don't think we're any busier than the pediatricians, but for some reason, the pediatricians just do it really, really well. Hats off to Michelle Ravelli.
A related question to what you've just been describing, are there some general tips that you would give people in terms of how they communicate with healthcare providers? I think you laid out a little bit of it in the beginning in terms of like who's speaking to whom and things like that. But are there other things that would be helpful to walk into a healthcare setting, understanding, knowing, or bringing?
I think that first of all, you have to set a realistic expectation of what you expect from that visit. Whereas my child has no problem going to the doctor, he lives with 2 doctors. There are some people, and a dentist too, he could care less. He sits there, opens his mouth. But there are people who are very sensitive. Different sights, different sounds, different people. So if your son or daughter or family member has some real issues, I think those need to be discussed ahead of time and make the physician or healthcare provider aware of the fact that your loved one may not be able to sit still. Your loved one may be loud in the waiting room. A lot of times I'll tell people either take the first appointment of the morning because it's quiet, or take the last appointment of the day because then they usually tend to have a little bit more time and the office is sort of slowing down. So those are the 2 ends of the spectrum that I would definitely recommend. A lot of the conversations I like to have, I like to do it ahead of time. So if I tell people, if people tell me they've got some concerns, I have a new patient coming in and he or she may have an intellectual or developmental disability, I'll get in touch with them ahead of time. What are your expectations? What do you hope to gain? What can I do? And I do it incrementally. There's someone who I'm going to see for the very first time. He doesn't do well. He can't wear a mask, so he can't come into the hospital. So I said, okay, I'm going to go out to the car. I'll give him his shot in the car. And it may be the first time that the individual doesn't feel comfortable in a healthcare setting. You go out to the car. I won't wear my white coat. You tell them my loved one is afraid of a white coat. Don't put your stethoscope around your neck. There are a lot of things that can be done ahead of time to make it a much more positive and pleasant experience for everybody involved. If you're as up and personal with the individual, I think that as a physician, I would appreciate it. Let me know what I should and shouldn't be doing. And that'll help us to get along famously. And it may take 3 or 4 visits before I actually lay a stethoscope on someone's chest. I'm okay with that, as long as they're okay with it.
Does Chad have a website?
We did have a website. Oh my God, now you're taxing my brain. It's been so long with COVID. I have not been multitasking. We have a Facebook page. I think we have a website. How about, let me look it up and I'll get back with you.
Okay.
We did. It has not been monitored in quite a while because everyone has been so single-minded with COVID, and that's totally my fault too. But I'll get back with you.
This is a great question. Is there a form or an outline or list of questions that families can use as a guide? Things that we may not think about in advance of bringing our loved one to a new doctor?
So I don't know that I've seen that. I have sent out, when I was in private practice, I have sent out forms ahead of time. There are a lot of people who do send out forms ahead of time. And they're pretty standard in terms of looking for social history, family history, past medical history, that kind of thing. I don't know that I have seen one that is geared toward our population. but I can certainly look for that. And if I find a good one, I will send it to you.
Thank you. Are there any other questions? Yes. Are the provider specialists who have received training from CHAD listed in any public way, or is it something that you might ask providers directly?
So we did a survey that we sent out and got about 100 responses back, I think, of people. We looked for people, we asked people, did they have a provider that they like to work with, that they thought was good for our community? And they gave us the name, and we put a little pin in a map of Connecticut. So that map is there. Again, it is probably 3 years old, maybe now. Again, we have not vetted these people. These were just the people who returned the survey to us. And again, I used a friend of mine who I thought was a really good barometer, and we just had a disaster of a time with the psychiatrist here. So I can't vouch for anybody at this time. And again, healthcare providers don't necessarily want to be known for taking care of our population. We tried to start a clinic at my hospital where I'm working, and they were very excited, very enthused about it, working with this marginalized population, and I was going to help develop this whole new plan, and they had people that they were going to ask for to finance everything, and then COVID hit, and then everything went to pot. So I have some people that I really, really like, and again, I would be happy to give that information out to people if they want to. I won't do it publicly. I'll do it privately. But there are some really special people in our community who have done a remarkable job of including our population into theirs. So yes and no. There is a map out there with some pins in it. I have not vetted them at all. These are just from family members who returned the survey to us.
Thank you. I'm not really trying to put you on the spot, Dr. Weisinger, about this,
Yes.
But do you think that there's a possibility that we might get the slideshow and be able to put it on our website?
Yeah, sure. Absolutely.
Very good.
Again, with a disclaimer that I'm not an expert in medical issues associated with IDD, but certainly these are just some of the things that we should be aware of. These are not an exhaustive or a comprehensive list, but certainly the top 3 or 4 things that we need to be aware of for our loved ones are included in these slideshows. You're welcome to have them.
Okay, we might also post a link to that map, because I think that one of the great things about this medium that we're using to communicate is that it gets to people in rural areas, other areas where the accessibility to healthcare is not that great. And so knowing somebody that might have experienced a CHAD training session would be a very good thing.
And if you have providers that you really like to work with who are wonderful for a variety of different reasons, I would love to get their names and addresses so I can include them in the map and update that. We are the best barometers of what works and doesn't work with our loved ones. So I would love to get some more feedback of who you work with and who works with us.
That's great. Any other questions, folks? There's your contact information.
That's me.
Fantastic. Okay, that's good.
So if I can help you in any way, please don't hesitate to contact me. And again, if you have some feedback for me, I would really, really enjoy that. I hope it was helpful. I'm not so sure if it's not helpful and you want to go in a different direction, I'd love to get that feedback also.
I think from the commentary, I think people have found it very helpful. So thank you very much for being here. Thank you everybody for coming, and thank you for bringing your questions. And also thank you very, very much for typing in the resources that you found helpful into the chat. Please stay tuned for our next presentations, and that we have our contact information that we'll get from your logging in, and we will send you those announcements. Thank you, Dr. Weisinger.
Thank you, everybody. I really appreciate it. Thank you,
Well done.
ARC, for having me, and let me know if I can help in the future.
Thank you, and good night, everybody.
Good night.